Perfusion imaging transforms contrast dynamics into vascular biology. DSC, DCE, and ASL each measure different aspects of circulation, including blood volume, blood flow, transit delay, and permeability. DSC, DCE, and ASL address distinct perfusion questions. DSC focuses on blood volume and delay, using a GD bolus and T2*/T2 EPI. DCE assesses microvascular leakiness with GD and dynamic T1 imaging. ASL quantifies CBF without contrast, utilizing magnetically labeled arterial water. Gadolinium creates microscopic field gradients, causing opposite effects in DSC and DCE due to different readouts. DSC sees a transient T2 signal loss, while DCE observes a T1 signal rise and models plasma to tissue exchange. ASL uses an endogenous label, relying on small subtraction. CBV, CBF, MTT, and Tmax are distinct metrics. CBV is blood volume. CBF is blood delivered per time. MTT is average arteriovenous transit time. Tmax is the delay to peak residue function. Remember, the central volume theorem links these three. CBF equals CBV divided by MTT. The DSC workflow converts the first pass signal dip into RCBV and delay maps. This involves a GBCA bolus followed by fast EPI acquisition. The signal is converted to delta R2 NIME, combined with the arterial input function and deconvolution to yield CBF, MTT, and Tmax. Finally, integrating this yields the RCBV hotspot map. Leakage correction is crucial for accurate RCBV, as enhancing tumors break the blood-brain barrier. Uncorrected images suffer from T1 shine-through and T2 asterisk residue, biasing RCBV. Correction involves shaping the acquisition and modeling the leakage term during post-processing to isolate the vascular term. DCE adds permeability information. The kinetic model tracks contrast agent movement between the plasma space, defined by VP, and the extravascular space, VE. K-trans is the transfer constant or permeability. DCE is slower, but directly visualizes BBB leak, rather than treating leakage as a contaminant. ASL, or arterial spin labeling, forgoes a contrast bolus for repeatable quantitative CBF. The process involves labeling arterial water, delaying the acquisition for arrival, subtracting label and control images, and quantifying the CBF map. ASL is useful when contrast is undesirable, offering longitudinal and pediatric-friendly absolute CBF values. Glioma grading is a hotspot problem, not a whole lesion average. Higher-grade tumors show distinct hotspots compared to lower-grade patterns. Interpretation rules include sampling the hottest solid tumor and avoiding necrosis and large vessels. Normalization is key, though thresholds vary by protocol. Higher tumor flow generally correlates with grade, but histology is decisive. Recurrence and radiation necrosis can be separated imperfectly by vascular activity. Recurrent tumors often show elevated RCBV-CBF and may have increased permeability. Radiation necrosis typically shows low or absent hyperperfusion and variable DCE leak. Ultimately, the best read combines perfusion with diffusion, enhancement pattern, timing, and treatment history. The stroke penumbra represents a mismatch between delayed flow and the injured core. Low CBF core areas subtracted from Tmax greater than 6 seconds territory approximate the penumbra volume. Common automated examples use a relative CBF cutoff for the core and a Tmax threshold for hypoperfusion. A clean perfusion read follows a checklist every time. Address the clinical question, know the technique and tracer, perform quality control on motion and artifacts, use appropriate metrics without blending them, apply leakage correction when the blood-brain barrier is open, and synthesize the physiology with uncertainty and context. Perfusion is physiology, not a color map shortcut.